Hello, my name is Sarah Lycan, and I am a lead advanced practice provider, or APP, on the implementation team of the COMPASS study at Wake Forest Baptist Health. I am very happy that you have come to sit down with us today. It will be helpful for patients to receive the same messaging about how patients can find their way forward to recovery, independence, and health. In this presentation, I want to introduce these messages to you as you will be part of the team providing post-acute care through the COMPASS model. Here are the key messages across the 4 directions of the COMPASS, and we will continue to go through these messages in this presentation. Know your numbers. Be active, engaging both mind and body. Ask for help and support. Be willing to become involved in medication management and lifestyle choices. As members of the COMPASS team, we provided you with a checklist that can help remind us of how we can help a patient in the COMPASS study. I will continue to refer to this checklist in the presentation. Each patient will have an individualized e-care plan after the 7 to 14-day follow-up visit that highlights the most important concerns unique to this patient. It will also display the reasons the patient wishes to find their way forward to recovery, independence, and health, such as wanting to get back involved with family or make certain family events, or as simple as being able to walk without assistance. The e-care plan is best used as a guide to help focus the interventions you plan for your patient. How can you help encourage the patients to know your numbers? By knowing their numbers, patients become more involved in their own health. It encourages self-management of chronic diseases. A major treatment goal for patients who have had a stroke or TIA is to prevent more strokes from happening. The following numbers represent a generalized guide on secondary prevention targets and therapeutic choices that you can convey to patients. Most of these are coming from a comprehensive guideline for secondary prevention, which may differ from primary prevention. Generalized blood pressure goal for post-acute stroke or TIA patients is a goal blood pressure less than 140/90. An INR goal between 2 to 3 for those with atrial fibrillation, and 2.5 to 3.5 for those with mechanical heart valves. For cholesterol, we encourage patients to be on high-intensity statins to reach LDL target goals of less than 70 for those patients with diabetes, and less than 100 for those with atherosclerotic disease. For those patients with diabetes, a hemoglobin A1C of less than or equal to 7 would be ideal. However, the target may be higher in some patients based on age and comorbidities. We understand the complexity of each patient, and you may need to consult other colleagues such as neurology, cardiology, and primary care providers for individualized patient goals. If their patient's blood pressure or INR or any other number goals are outside of the standard norm, then that information will be on the patient's individualized e-care plan. We want every discipline, such as therapists, nursing, case managers, to know what numbers to teach their patients and to reinforce the importance of secondary stroke prevention. This teaching is not just the role of nursing as traditionally viewed in home health care. Blood pressure is a major risk factor of stroke. There is more evidence that home blood pressure monitoring can be beneficial. Patients in the COMPASS study are being encouraged to really become involved in blood pressure management. We are asking every provider, therapist, any point of contact with the patient to take the patient's blood pressure. We want every member of the team to be able to counsel the patients on the results of their blood pressure. Help the patient understand the importance of maintaining an optimal blood pressure. Please help patients record their blood pressures in a patient log and take that log to all office visits. We should be mindful of taking blood pressures correctly and teaching our patients how to take the blood pressure correctly as well. How can you help patients manage their medications? At the 7 to 14 day visit, the assessment performed helps to determine, can a patient manage their medications? If they cannot, then why not? What are their barriers? How can we overcome the barriers that have been identified? The e-care plan will summarize these barriers and give suggestions of ways to improve medication management. Common barriers are cognitive impairments, low health literacy, lack of caregiver or social support, depression, and very commonly financial barriers. The checklist reminds you of how to help a patient. Encourage them to speak to providers and pharmacists if they have financial barriers. Refer patients to specialty community pharmacies who may provide special services for those patients who are at highest risk. These pharmacies can provide blister packs. They can go into the home and help with medication assessments, and they can help find medications at a better cost. Refer to our website for a list of these pharmacies that may be helpful. The e-care plan will identify patients with common risk factors of stroke or TIAs, such as smoking, obesity, metabolic syndrome, alcohol use. We will refer patients to community resources that can include behavioral health providers, nutritionists, and for smoking cessation, a common resource across the state of North Carolina is the 1-800-QUIT-NOW line. The importance of engagement of patients with both their mind and body includes assessing patients for depression. Depression is common among stroke survivors. 30% of stroke survivors will develop depression, compared to about 5 to 8% in the general population. Those more at risk of depression are patients who have had a history of depression or anxiety, patients with significant physical disability and more severe strokes, and those with cognitive impairment. Depression may begin any time after stroke, mostly in the first year. Depression affects multiple aspects of a stroke survivor's recovery. It can worsen their functional outcome. It can affect their quality of life. It causes less efficient use of rehabilitation services. It affects their ability to make good lifestyle and behavioral changes that can improve their recovery. The assessment performed at the 7 to 14 day visit includes a screening for depression. The e-care plan will identify patients who are demonstrating signs of depression. Patients who have depression may be referred to community resources such as mental health providers. A statewide resource such as CareNet is a community-based counseling organization. Some communities may not have CareNet site, so other mental health resources in the community can be found on our Compass website, Community Resources Directory, or on the patient's e-care plan. We want to encourage everyone to counsel patients that therapy is a key part to recovery. We want everyone to encourage to get up to 10, 20, or 30 minutes of physical activity exercise, promote safety, mobility, and falls prevention. Everyone, this includes all members of the Compass team, should be portraying this message. That includes the APPs or advanced practice providers, or those who are doing the 7 to 14 day visits. That includes the PAC nurses at each Compass site, the primary care providers, pharmacists, home health, and all outpatient care providers. For patients who have swallowing or language deficits, we should encourage them to participate in speech therapy. Encourage them to adhere to diet recommendations such as those with thick and liquid diets, and encourage them to participate in repeat swallowing studies that may be needed. As home health or outpatient providers, we should assess patients that may benefit from a formal speech therapy consult. On your screen is a list of symptoms of patients that may benefit from formal communication therapy. Also consider referring patients to community resources such as support groups that may be online or in the community, online applications for smartphones that can help with communication at home, and also for patients who may need repeat driving evaluations. We encourage you to also assess for signs of trouble swallowing and identify those patients that may benefit from swallow therapy by a speech therapist. Those with dysphagia are at high risk of aspiration. Remember, patients with brainstem strokes may have silent aspiration. Just because they are not coughing does not mean that they do not have dysphagia. For those patients who have dysphagia, they are at risk for dehydration. On your screen are a list of who may be at the highest risk, what are the signs of dehydration, and what are treatments that may be needed for those with suspected dehydration. How can you help be a part of this Compass team and help your patients? At the time of discharge from formal therapies, we ask that in your discharge summary that you do include the therapy visits and that were provided that you often do. But in addition, please provide any referrals that you have made after the patient has completed formal therapy to such things as community resources. These can be the Area Agency of Aging, senior centers, local support groups, local physical activity resources. Please include these or any things like Meals on Wheels in your discharge summary. Also, if you have any, if you need a list of these resources, please refer to the Compass website, or they may be listed on the e-care plan as well. In the end, we want to promote self-management of patient in order to obtain optimal recovery, independence, and health. Thank you again for being able to listen to this webinar, and please refer to our website for any questions that you may have or the Compass team, as we are here to support you through this intervention. Thank you.